All right. Are there any adjustments or additions to the agenda?
Madam Chair, there is. I do have one additional agenda item under budget amendment, new business for the board's consideration.
Okay. So instead of 3, there are 4.
That is correct, ma'am.
All right, we'll accept all that money. As long as you're not taking any away. All right, so notice, I'll need a motion to approve the agenda.
Move for approval of the written agenda with the said correction.
Second.
Okay. Roll call vote.
Dr. Jackson,
Yes.
Dr. Miller, Dr. McDougall,
Yes.
Mr. Curtis,
Yes.
Dr. Breakway,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
Commissioner Alam,
Yes.
Mr. Gregorio.
Yes.
Thank you.
Okay, motion passes. Hopefully you had a chance to review the minutes that were sent in your mailings from our June 9th meeting. Are there any corrections or additions to those minutes? Okay, hearing none, I'll entertain a motion to approve the minutes.
Motion
So
to
moved.
approve the minutes.
Second.
I'll take that as a move and a second that came in simultaneously. All right, roll call vote.
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. McDougall,
Yes.
Mr. Curtis,
Yes.
Dr. Breakway,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
Commissioner Alam,
Yes.
and Mr. Gregorio.
Yes.
Thank you.
Okay, motion carries. Minutes are approved. Are there any public comments?
None that I have received.
Okay. All right, Director Jenkins, any staff and/or program recognitions?
Thank you, Madam Chair. Just staff, I just want to really lift up the continued COVID response relief that the entire staff has been undergoing for close to 3 years. But I particularly want to really acknowledge, applaud our CD staff, because as you will hear in a short while, monkeypox is here in Durham, and responding to monkeypox has not been such an easy feat, but they have been doing a fantastic job, from our preparedness coordinator to our medical director to the entire CD staff to our PIO, Dr. Alicia Smith. I just want to really recognize them for taking on yet another virus and getting the word out. That's all I have, Madam Chair.
Okay, yeah, thank you very much. Yeah, I'm looking forward to the update on monkeypox. Thank you. All right, administrative reports presentations. So we're going to get an update on our family planning services from Assistant Director Liz Stevens and Tonya Luna.
Wonderful. Thank you so much. Good evening, Madam Chair, to our Board of Health, Director Jenkins, Attorney Wardell, and of course, my wonderful colleagues. I am going to start sharing my screen. And I'm hoping that everyone can see okay. Okay, great. So I'm really happy to be presenting to you tonight along with Tonya Luna, who is our Women's Health Program Manager over our Women's Health Clinics. Myself, one of our Deputy Directors, also currently serving as the Interim Director of Nursing. And we are joined by Dr. Maria Small. She is our Medical Director for our Maternal Health part of our women's health program, and also a maternal fetal medicine specialist at Duke. We were hoping to be joined by Dr. Venetia Wilson, who unexpectedly got called over to the VA. So she may be coming on later, but got called into clinic unexpectedly about an hour ago. And I believe Dr. Small is jumping on as we speak. So I am going to today, there we go. This evening, we hope to give you an overview of our services offered at the Family Planning Clinic here at Public Health. We also want to talk about some of the requirements of our Title X program funding, as I know that's been a question that several folks have had recently in the past few months. And we also just want to highlight some opportunities for increased support for our family planning clients. As Tanya and I speak, you'll hear us talk a lot about the family planning side of the clinic and then the maternal health side of the clinic. For those of you who have been into our second floor clinical space, it's one long clinical area with either clinic on each end of a hallway. And I think that's really fitting as we think about our patient population and the fact that our patients move between the maternal health clinic and the family planning clinic, simply depending on whether they're pregnant and seeking prenatal care, or if they are trying to become pregnant in between pregnancies or receiving care postpartum. So you'll hear Tanya and I talk about both parts of our women's health program relatively fluidly. So to begin with the overview of the goal of our family planning services, I really looked to two places. We abide by our North Carolina Department of Health and Human Services Agreement Addenda 151. So you'll hear us refer to that as AA 151. This is the agreement addenda that really dictates what our services need to look like in family planning. And it's a part of the women's health branch within the reproductive health unit. The mission of the reproductive health unit is to reduce unintended pregnancies and to improve specific health practices among low-income families specifically. The other place that I look to as a source for our goals of our services is right on our Durham Public Health website. So you'll find on our website, on the family planning page, that the family planning area, it aims to provide education, counseling, birth control methods, and to decrease the number of unwanted pregnancies or to prepare for a healthy pregnancy and baby. So we really make a big effort within our women's health program to provide full scope services from the time, the full reproductive life course, from the time that a woman first enters reproductive age through menopause. All of our services are confidential, and it's really important that our clinic is welcoming and comfortable. We have many staff within our family planning clinic who have been there for a while and who I think do a great job of really tailoring our services to the clients that we serve.
Some of the services that we have here in the clinic, we do provide contraceptive services, which includes referrals and prescriptions for methods that we do not have available on site. We have many of the methods on site, but I'll talk about a couple of the ones that we don't on the next slide. We do offer emergency contraception, pregnancy testing and counseling, achieving pregnancy services. If a woman wants to come in and plan for a pregnancy where she's wanting to achieve pregnancy within the next year, we kind of talk with that about how we can make those things happen. Basic infertility services, preconception help services, reproductive life planning throughout the different stages of their reproductive health. Services for sexually transmitted infections, which of course we all know does affect our reproductive health throughout our lives as we go. Relative preventive health services such as screening for breast and cervical cancer. And we do offer adolescent friendly health services that they can seek treatment without a parental consent if needed. We do encourage them to inform their parents, but we can service them without that. So that does not create a barrier there. On the next slide, you can see we have a tiered approach for our counseling. And we usually start towards the bottom. We'll talk with the client about the reproductive life plan and whether or not they're wanting to conceive or achieve pregnancy within the next 3 years. And if it's less than a year, we'll typically talk about the methods on the very bottom, which would be the withdrawal, diaphragm, fertility, and condoms. Those are the least effective methods and would be the ones that we would, tell the client that if you're not really trying to prevent pregnancy, but you're not ready to get pregnant this moment, this would be the one to go with because the likelihood of preventing pregnancy is much smaller with those. The middle tier, which is the ones that are okay coverage, they do require some additional investment by the client. For example, the pills, they have to remember to take that every day. They need to take it around the same time every day. And for some people, that can be a little challenging. They do also offer the patch, which we do not carry here at the facility, but we can get that a referral and a prescription for that to get outside the facility. That lasts for a week at a time. So they would have to remember to change that every week. The ring, which is a ring inserted vaginally around the bottom of the cervix, that has to be changed every month. So again, the woman's commitment has to remind that for every month. And then the shot with Depo-Provera prevents pregnancy for 3 months. This is usually the recommended method that we would talk when someone's wanting to wait between 1 to 3 years to achieve pregnancy. We would discuss the middle tier. The top tier is the one that is the most preventive method. Obviously, the long-acting reversible contraceptives is referred to. They're called LARCs. And the implant and the IUDs are the ones that we have. We do have all of those on site, and we do offer same-day insertions on those. On average, in any given month, we insert about 25 to 30 Nexplanon devices, and we insert 10 to 20 IUD devices per month with those. And of course, we have sterilization up there at the top. And that's if you don't want another baby ever again, that is definitely the method that you would choose. However, once you are sterilized, you're no longer able or qualified to receive services from family planning because you no longer can have children. So that's the approach for our contraceptions. We do make sure that we provide counseling and education for all of these, along with the risk and benefits for each one. Some women come in and are not sure when they want to have a baby or how long they want it to be. So we kind of go through each process and talk about the risk and benefits and the commitment from the patient with each one. So that they can make an informed decision. We never use coercion. We actually just talk with the client and make sure that they have the information so that they can make the informed decision when choosing the best birth control for them. Next slide, please. On this slide, you'll see some data with our total clients through the last 4 years. The 2021 numbers dropped obviously because of COVID, and we were not seeing across the nation, we're not seeing the kind of visits and clients and some of the services we did not perform as full-time access. So we expected that number. There has been an increase in 22 thus far to our client base, and I suspect that will continue to increase. As you see, there's been an increase of our number of implants that we're placing as well from past years. We do continue to expect to see that trend moving upward, especially as we move forward with the new ruling and the rollback of Roe versus Wade. We don't really know the impact that that's going to have as far as our LARC inventory, but it's already been increasing, so we expect that to continue.
I'm going to talk a little bit more about Title X and really some of the requirements that this funding mandates of us. So Title X makes up a portion of our funding of our family planning clinic. I'll talk about that in a minute. But there are some really specific trainings and requirements for clinics that receive federal Title X funding. All staff, and not limited to the clinic staff, all of the registration staff, all of the staff in the lab and the pharmacy, really anyone working with a client that is being supported by Title X has required annual training related to child abuse, reporting of child abuse and neglect, human trafficking, racial equity. The training is pretty substantial and I think is really a huge benefit to our staff for public health overall. There are specific requirements about the fact that no client can be turned away based on an inability to pay. So we use the federal poverty level sliding fee scale that is put out each year from the family planning program. That's actually the sliding fee scale that we adopt for the entire health department for consistency's sake. Title X also requires that clients have access to 340B medication. And as you all know, we have a robust 340B program that has been ongoing for several years. Another requirement is specific to adolescent services. So basically mandates that we have to be considering our services to meet the needs of our adolescent population. So Tanya mentioned that there's always the option for a client to have a confidential visit, right, related to reproductive care or related to certain types of care for sexually transmitted infections. That's one part of that, but it's also about how we teach and how we communicate and what our materials are like that have to be tailored to meet the needs of adolescents as well. And then there are also some really specific signage and policy requirements related to non-discrimination, things that have to be present in the clinic according to Title X. So I pulled some specific information. This is a lot of reading right here, but it's specifically out of AA 151 that talks about Title X and talks about what we can do in terms of the counseling and the reproductive life planning and the tiered approach that Tanya spoke about related to Title X. Essentially, our staff are not able to perform, promote, or support abortion as a method of family planning. We have to offer pregnant patients the opportunity to be provided with information and counseling in a very non-biased and objective way related to pregnancy termination, prenatal care and delivery, and infant care, foster care, or adoption. So those three options have to be kind of laid out there to a client in a very equal, non-biased way. We are not able to, if a client is interested in termination, there are certain things that can be counseled by a registered nurse and other things that can really only be counseled by an advanced practice provider. As some of you may know, we do have 2 county nurse practitioners within our family planning clinic who are able to counsel clients. And then, like I mentioned earlier, our providers in the maternal health clinic often work closely with our family planning providers if we have a particularly complex situation or question come up. If a patient requests information on the different options, like I said, it has to be really neutral, really factual, non-directive. And that is what our staff are allowed to do. So I mentioned I was going to, sorry, go ahead, Tanya.
I thought that was my slide.
Go for it.
So some of the things that we wanted to kind of talk about was our overall family planning budget and kind of how we get the sustained long year access and the funding for those devices that we purchase. Our total family planning budget is around $919,000, with $132,000 of that supporting part of 4 positions. And then we have about $720,000 of county funds that is all of our operating budget and funds and things that go into that. But for the LARCs, we have TANA funding, which is, it is our out of wedlock pregnancy prevention program. And we spend the entire $34,000 on LARC devices, as well as the Women's Health Service Fund. These are for any women of childbearing age. All of these women must be uninsured or underinsured. And then we have county funding that varies from fiscal year to fiscal year. And at the end of the year, if there's any additional county funding, we always use it to purchase LARCs because that's where we have the biggest need. And I think the biggest hole in our services are at. We also have $60,000 in funding from Healthy Mom, Healthy Child grant that also goes to support 2 family planning positions in the clinic and to help with our services and things that outreach for all of our funding. So even though we've got several different funding sources, we are always looking for more ways to purchase LARCs because that is the most effective pregnancy prevention thing out there. So we're always looking for ways to find that. So next slide, Liz.
Great, thanks, Tanya. So as we think about opportunities for growth, like Tanya mentioned, the purchasing of LARCs is a big one. She can probably hear me in her ears at the end of the fiscal year saying, what extra money do we have and how many LARCs are we going to purchase with it? We try to be really conscious of that as we get towards the end of the fiscal year to use any leftover county funds wisely. So that is a need. Other needs that I think we've worked with Dr. Small and some of our other providers and community partners on relate to just that supportive care that's needed for our clients. We take care of them in the clinic, but the care that's needed does not stop there. We know that there are big needs for postpartum support out into the community, extending well into that first year or two after a woman has a child. And this is support for the whole family. This isn't just for mom and baby. We also know that there's always work to be done around adolescent health and healthy relationships, teen healthy dating behaviors and understanding coercion and being thoughtful around recognizing human trafficking, like I mentioned previously. So these are areas where we feel like there is always room for growth. And I'm proud to know that some of our work recently with our Black and Brown maternal health community-based organizations has been in an effort to try to work on some of these pieces. Lastly, another opportunity that a few folks have mentioned and have kind of brought up, I know both to Director Jenkins and to myself, is the idea for some sort of a community fund to support individuals who might be seeking services outside what we offer in our family planning clinic. So like we've shared, there are certain things that we can and can't do within our clinical services, but if there's a need in the community outside that scope, then that could certainly be something that the county or the city nonprofit private partners could certainly look into establishing. This is something that's been done in other communities around the country, as I'm sure many of you know, and Durham would not be the first to kind of help aid access to reproductive health services in this way. So I'm going to stop us there. Tanya and I wanted to leave some time for questions and discussion. And I believe Dr. Small was able to join us as well.
Thanks, Liz. We certainly would love our great partner, Dr. Small, to be able to comment, give you guys praises on that wonderful presentation. Dr. Small,
Yes.
The floor is yours.
Okay, I'll just give a brief thank you to the partners in the health department and also just acknowledge that we're in a very critical time now for women's reproductive health and support for the entirety of health for individuals both during and after pregnancy. One of the critical needs that is going to get larger in Durham, as was highlighted, is the need for really reliable contraception. And already those LARCs, are those long-acting reversible contraceptive methods, are things that we sometimes run out of in our health department. And we run out of them at a time when we aren't in the critical period that we are now. And we anticipate that those needs are going to get larger. And so that's one area that we really need to think about providing maybe additional resources support for. And then just in general, some of the community-based efforts, community-based organizations, navigators are other folks that can help support people when they're transitioning in times that are challenging, difficult, facing challenges in pregnancy and beyond pregnancy, prior to pregnancy, and even adolescence. And also doulas who can support people even in as they have faced challenges with pregnancies that are desired or unplanned and after. So I think these are some of the folks in our community that we have as resources that we could consider providing additional support for if available. So with that, I'll pass.
Back to you, Madam Chair.
All right, thanks so much to the team for that very good presentation and very informative. That was really good information. Thank you so much. Are there any other questions or comments for the team, the family planning team?
Yeah, I've got one
Commissioner Lum?
question. Go ahead.
I'll let Jean go first.
Okay, no problem. Just a quick question about, you mentioned, Dr. Small, you sometimes run out of the LARC products, and those are your most popular products. Just a question around the logistics of what happens when you run out of products. How long is that gap? And then, is there a process for referring a patient somewhere else to get those, or do they get offered one of the alternative methods?
Liz, I'm going to refer that one back to you.
Yeah, I'd be happy to speak to that. Thank you for that question. So all of the above. Sometimes we refer clients to partners at Lincoln or at Duke, depending on what's going to be logistically possible for that client and family. Other times we will give a bridge. For example, we might give a woman 3 months of a depot injection, knowing that in 3 months, we're going to have another order of IUDs in the clinic, and then we'll schedule her to come back for that time. So we certainly, I would like to say that we don't, we do everything we can to keep those clients from falling between the cracks, but it does present a little bit of a logistical challenge. And honestly, additional appointment that they need to come back to the clinic to get the LARC if it's not going to be available for, a month or two.
And sometimes those interim options are not favorable to a particular individual if they've had depot or they're not a candidate for pills because of medical conditions. So it can be challenging, and that is a challenge.
And the gap it's funding based. It sounds like you run out of. There's not a lack of supply of products. You just don't have the funding to purchase the next amount you need.
Yeah, it tends to be towards the end of the fiscal year when we have used everything we've got, and we're trying to find that funding to order more.
And the trend now is that people are more because of the changes in the laws, legislation, uncertainty. People are really looking for more reliable, the most reliable methods.
Thank you very much.
I think Commissioner Lum is next.
Sorry, I was using 2 screens. I was trying to find my mouse. Thank you so much, Dr. Jackson. And thank you, Tanya, Liz, and Maria for this presentation. Yes, I know Director Jenkins has heard a lot from me. We've had a lot of conversations back and forth about this. So I'm really glad that we're having this discussion as a full board. I did have a few questions, and Director Jenkins, this came up after the call I had with you and other staff that I was talking to the general counsel over at Planned Parenthood, because I was just trying to figure out, I know they also receive Title X funding, and seeing how they kind of maneuver accepting and receiving Title X funding and also being an abortion provider, and wanting to hear, and obviously they're not a government entity. So what restrictions exist for us? Because I was looking at, they had sent me the Health and Human Services website that showed the separation of services, that if abortion services are provided, they have to be delineated in the budget from Title X funding. So is that only something that groups like Planned Parenthood and our clinics can have that delineation, or can government entities like the Public Health Department have?
Again, Commissioner Lum, and I welcome feedback from Liz and others, but it has been our tradition to not, have those services done, because it has been frowned upon by the North Carolina Department of Health and Human Services. Several occasions I've consulted with our legal experts, to include Jill Moore from the School of Government, to include retired legal counsel for DPH, Chris Hoke, several others, and they've all said that that's just simply something that we don't do in public health. However, through your research with the General Counsel for Planned Parenthood, being that there are an entity that is set up and specifically designed for that particular activity, they have the ability to delineate, but public health departments have not, and to my knowledge, have never been set up to do this kind of work.
Thanks.
Some of
And I know
the
that we're gonna
requirements and
talk-
regulations for being able to perform terminations are fairly extensive and costly. I think that is, would be a big challenge. And for the resources that are available to the county, we could really use the LARC support, for something a service that we already provide, knowing that we would have quite an extensive amount of change and regulatory hurdles to overcome in order to be able to provide those services in the health department, when we also have access to those services fairly at similar cost ranges in Durham through our Ryan clinics.
Dr. Small, can I ask a question?
Sure. Hello, Dr. Breathwaite.
So, and I think Commissioner Alam's question is very intriguing and important. And I like the way what I'm hearing, but what I want to hearing the right thing. Are you saying that there is access to termination services in our area?
Absolutely.
And,
yes.
And that it's not limited. Those who seek those services through the health department can be linked to a provider in a timely manner.
Yes, and the providers that are in charge of providing those services also provide services at the health department. So they can provide a seamless connection to individuals who would seek those services as well.
Thank you.
They may even see faces that they're familiar with in both places.
Okay, great. Further questions?
But that doesn't mean that also supporting, there are doulas and navigators who help with like their abortion doulas that could be supported as doula services. Doesn't have to be necessarily detailed what type of doula people are seeking, if that is something that's needed for your budgetary purposes.
I have two more questions.
No, you're fine. You're good.
Thank you. And I just wanted to clarify because, like reading the presentation, I just want to make sure, when I go on and talk to folks about the separation of referrals of not being able to, actively advocate for abortions from public health department, but Title X does not bar us since the Biden administration's changes that we can refer patients to abortions if they ask for that care. We just
Yes.
can't actively be saying or promoting.
There's no gag rule in that respect.
Okay. And then I had one more question. Oh yeah, the support of outside, like a community fund. That's something that Dr. Jenkins and I have also talked about, because there are a lot of different funds, especially as North Carolina is one of the few states, because we all know that's still currently legal for abortions. I know our board members have been talking about that, various, and the Board of Commissioners has been talking about various options and meeting with Dr. Jenkins about, pushing the line. I know he knows that I'm still in my heart want public health department to provide these services, and I will keep researching and asking questions. But if, we're not able to, I'd really like to see us, moving in that way of providing a community fund and support. And I'm really glad that that was included here for us to explore, because we have services and clinic providers. I think Planned Parenthood in Durham does not provide abortions. Chapel Hill location does. The North Durham, there's a clinic up in North Durham that does. I think under the state's website, are there any other clinics located in Durham that provide there, or are they in other neighboring areas?
The Ryan Family Planning Clinic at Duke provides termination services. And obviously for some of the reasons that you know of, I don't know that we widely advertise that, but I think that people are given that information and can be made aware of that availability. Dr. Beverly Gray, who's co-medical director and in charge of family planning, is also the past director of the Ryan Family Planning Clinic. So in terms of some of and she's spoken at the state level and obviously nationally about, she couldn't be on this meeting, about access to reproductive health services, full access to reproductive health services, which includes abortion. So one of the things that can be discussed, and certainly I'm not taking up the rest of this meeting, but obviously it's a very important issue, but how the fund, what type of fund could be available to maybe have individuals, if not the county itself, provide support for people coming to our Durham County Health Department who need and desire termination services.
Yeah, I would love to schedule some time with you maybe later on to talk about that more.
And maybe we can also include some of our community partners who would be active in that area and some of the family planning folks.
Yeah, that sounds good. Thank you, Dr. Small, for that. Yes.
Madam Chair, I
thank
know
you.
that we spent a significant amount of time, but I would feel bad if we did not give Dr. Venetia Wilson an opportunity to speak. She did
She's on.
join us, and
She's on?
certainly want to give
okay.
her an opportunity to talk since she collaborated on the presentation.
Okay, all right, great.
I do apologize for being late. I had an emergent OR case, so I got here as soon
No
as I
worries. Thank you so much for joining.
So I didn't, I saw Liz's presentation ahead of time. I don't think I necessarily have any additional information to add besides what, like, the questions Dr. Small has added in terms of like what is the resources that are available to our patients at our clinic. And there has not been an issue in patients accessing those services when they ask for them. And I think, as Dr. Small said, it's a lot of the same providers that we're at the health department. We're also at the family planning clinic as well.
Okay, great. Thank you. Thank you so much. All right, are there any other questions or discussions? So I hear that Commissioner Alam is going to continue her research. And I don't know if all of you know this, because I did not know this, and I guess it's okay for me to say, I didn't realize that you were pregnant.
Yesterday was my due date, so I am one day
wow.
past my due date. I am sitting on a medicine ball. Dr. Wilson, I might see you at Duke Regional soon.
Oh, well, congratulations. Congratulations.
Thank you.
Yes, yes. So thank you, though, for your interest, Commissioner Lum, and your research and bringing this discussion to the fore. So we look forward to discussing a little bit more. So thank you all very much. All right. Let's see. I was so engrossed with that. Where are we on the agenda? Oh, okay. The respond to Board of Health questions to our public health vacancy report. Hopefully y'all had a chance to review that. I see we're still holding steady around 16% the past several months. So it hadn't gotten any worse. We had been up in the 20s, like close to 30% at one point. So Director Jenkins, you look like you were about to say something.
We had a rough couple of weeks, Madam Chair. September might not be looking too good.
Oh, okay.
I'm just kind of giving you a heads up.
All right. So how are those vacancies affecting day-to-day operations? Is any one area in particular being affected more? Are we still able to keep up with what we need to do?
We are. I would be remiss if that's an excellent question. I'd be remiss if I did not lift up our environmental health division. Some key areas on on-site protection, water protection, I should say, have been particularly hit hard. And as we know with environmental health, it's a long process to get fully authorized. So Chris Salter and his team, to include Laura Lurch and others, have been doing a fine job with kind of maintaining. But I am happy to say that we have been able to secure new hires But as mentioned, if they're not fully qualified, then it takes quite a while to get them up to speed. Otherwise, nursing is holding its own, and no real impacts to operations.
Okay. All right. Well, we'll continue to keep an eye on that.
Dr. Jackson, I have a question.
Yes.
Absolutely.
Not necessarily about the vacancies, but like how the Board of Commissioners, if there's ways that we can be more supportive. I know President Buxton at Durham Tech is really eager to, increase their nursing program. If there's ways that the Board of Commissioners and Board of Health and Durham Tech could maybe partner, and obviously I have to talk to the rest of the board. And I think that may be a really cool opportunity for us to explore if there's like a Durham Tech to public health pipeline.
That's an excellent suggestion, and we've done things like that in the past, and there's nothing wrong with revisiting it. We've also had some strong connections with Duke School of Nursing, particularly for our school health nursing program, and under the leadership of Lisa West. And we're starting to see some good fruits of our labor. So we are open to investigating any and all avenues in order to get these positions filled.
Okay, great.
I'll probably
And we
reach out to you.
had to resort to a lot of travelers. Have we? I think we might have it at one point, but I know another health organization I work with out of the air, the amount that they're spending on travelers to keep going. But we've been able to avoid that huge expense for the most part.
For the most part, different rhyme or reasons have been given for as to why people are leaving, but it's just, again, great resignation. People are looking at options, particularly telecommuting, remote options, and all of which we offer. But, again, hard to tell. It really is.
Yeah. Yes. Some things can't be done through telecommuting.
Indeed.
All right. Yeah. Anthony.
Yes, thank you. And just to, I guess, add on to Commissioner Alam's idea, we also have the City of Medicine Academy as well near Duke Regional for, pipeline for our early career talent here in Durham. So it'd be great if we could somehow partner with them as well.
Absolutely. We appreciate it.
Yeah. And Duke Regional works with both of them. I think Durham Tech and, of course, the Academy right next there on their campus. And so I think it'd be great for that whole coordination, because we all have the same needs and we're looking at the same people to do the work. So some coordination there. And while we mentioned Duke Regional, I was going to say it later, but I think this would be a good place to interject it. So Duke Regional's president, Katie Galbraith, many of you know, is retiring and leaving Duke Regional. She's been with Health System for 26 years and she's moving up to New Jersey. And actually her going away party is right now as we speak. So I just wanted to say publicly and for our minutes that we appreciate all of the work that she has done with the health department, particularly she and Rod the past couple of years, the way they've worked together in the COVID space. She has been amazing and support for them has been amazing for us. So I just want to wish her well and just let you know that she is leaving. She will be missed, but we appreciate everything that she's done. And there is a national search going on now for her position. Okay. Next, the NOV report. And I still see a lot of red on there and some purple, so things are happening. And I know environmental health is being stretched, but it seems like they're doing a really good job with trying to keep up with all of that. It's a lot. It's a lot. So thanks to them for that. Anyone from environmental health have a comment about that at all? Okay. And then the health director's report. Y'all are still very busy. So that's good. I see nutrition was reached recently at Lincoln for a men's health clinic in nutrition. And one thing I saw in there that I may have missed last year when it started was the Racial Equity Nexus team.
Absolutely. Thank you for mentioning that. I was going to ask if I could lift that up. I especially wanted that to be submitted in the health director's report, Madam Chair, and members of the board. They have been doing a mighty fine job of promoting racial equity principles and training throughout the entire agency. And this is not something new. Durham Public Health has been doing it for quite some time, but this is the first time that we've actually had a Nexus team officially with goals and objectives and everything. So They've also partnered with a consultant, Dr. Deborah Stroman from Race Realities. That's her company. So we are being very intentional about what we want. And we certainly continue to be the envy of the entire county's enterprise, as evidenced by a consultant that the county's racial equity team has. And we interviewed with her last Thursday, and she was quite impressed. But just want this board to know all that's going on with that.
Yeah, yeah. So that's good. Maybe sometime down the road, we can get a little update from them about what they're doing. I thought that was interesting. Great. And the other thing was, I see that the community health assessment for 2023 is starting up. So that's good for population health. So any other comments or questions about those reports? All right, any committee reports? I don't think we have any for this meeting. And under old business, this is our annual Board of Health policy review. It needs to be approved for our accreditation process. I think there are about, 10 of them, 8 or 9, 10 of them, just to be reviewed and approved. So hopefully you had a chance to review them. Anyone have any questions or comments or corrections regarding those policies and procedures? If not, I will entertain a motion to approve all of them.
So moved.
Second,
Okay, it's been moved and seconded. Roll call vote.
Dr. Jackson,
Yes.
Dr. Miller, Dr. McDougall,
Yes.
Mr. Curtis,
Yes.
Dr. Braithwaite,
yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
Commissioner Alam,
Yes.
Mr. Gregorio.
Yes.
Thank you.
Dr. Miller here. I'm a yes as well.
Okay, thanks. All right, motion carries. All right, under new business, now we'll get an update from Dr. Jinks regarding monkeypox.
Great, thank you, Chair Jackson. I will share my slides. Can you all see my slides?
Yes.
Okay, perfect. So just, I'm gonna do a little bit of background first. Try not to get too detailed, but I think, a lot of this is pertinent, especially because there's some misinformation circulating kind of out on social media and other environments. So monkeypox is an infection that belongs to the orthopox virus genus. So that genus includes chickenpox, cowpox, and smallpox, which has been eradicated. It was first discovered in 1958 in animals, and the first human case was documented in 1970. So not that new. We do certainly know more about monkeypox than we did about SARS-CoV-2 2.5 years ago. It's a zoonotic infection, which means it's got, it's a reservoir in at least one animal. Unclear which animal or animals, but thought to be likely rodents. As I said, it's been around since 1970. It's endemic in certain parts of the world. So there's clade 1 is endemic in Central Africa. That's the more, tends to be the more, cause more severe symptoms and has a higher fatality rate than clade 2, which is endemic in Western Africa. So the current outbreak, there's a little bit of controversy. I think most sources will tell you this is a spinoff of the clade 2. There are some people who feel like this may even be a new clade because it's behaving, relatively differently than the, what we've seen with outbreaks from clade 2 in Western Africa and elsewhere. So that's a little bit to be determined. We have seen outbreaks outside of these endemic areas. There was an outbreak in the United States back in 2003. That was the one and only outbreak that we've seen here. And it was thought to be due to, primarily due to the importation of some small animals who were infected with monkeypox that got imported to the United States. And so clade 1 tends to have higher fatality rates than clade 2. You know, I'll talk a little bit more later, but what we're seeing now with this current outbreak, very, very few fatalities. I think there's just been a one or a handful thus far. So you can see here, this is as of 2 days ago. This is the kind of the running total from the CDC website. So there have been almost 32,000 cases globally. Almost all, 99% have been cases outside of these traditional endemic areas. And that includes 89 countries where monkeypox is not endemic. So almost 10,400 cases in the United States as of yesterday. So we are by far, the country with the most cases. I think number 2 is Spain. They've had about 5,000 cases. So, we are, definitely first as far as cases, as far as countries around the world. In North Carolina, as of yesterday, there were 122 cases. And this is all information that's up on the North Carolina Health and Human Services website. So this is all publicly available. I'm not sharing anything that's not up on that website, but almost all cases are male. You can see mostly people that are young, and that mirrors kind of what we're seeing globally. The one thing that we're seeing different in North Carolina, at least from numbers in the rest of the United States, is that 70% of cases have been in people who are Black or African American, which is much higher than what we're seeing elsewhere. Only about 19% are cases in people who are white or Caucasian, and nearly all cases are in men who have sex with men. So how it spreads, by far and away, the most common way this is spread is close skin-to-skin contact. And this isn't shaking hands with someone, patting someone on the shoulder. This is 6, 8, 10 minutes of close skin-to-skin contact. And it's maybe not exclusively, but almost exclusively, skin-to-skin contact with someone that has a rash or lesions from monkeypox. I'll show some pictures in a couple slides. It's possible, because people can get lesions in their mucosa, that this can be aerosolized and spread through respiratory secretions. But again, this would have to be either prolonged kind of close face-to-face contact for that to happen, or uncommonly, but I suppose it's possible, if someone was vigorously swabbing a monkeypox lesion, and let's say unroof that lesion, there's a lot of virus in those lesions. If that got aerosolized, I think that it'd be possible to spread it that way, but that is by far not the most common route. Touching items, someone who has, let's say, was hospitalized, and there are scabs or pieces of monkeypox lesions in the bedding, someone that was changing the bedding, possible to transmit the virus that way, but that would not be common. And then transplacentally common, or possible, but not common at all. So really it's, close person-to-person contact, skin-to-skin contact is by far, the most common route of transmission. It's what we're seeing with this current outbreak. So signs and symptoms. So traditionally, before this recent outbreak, most people had fevers and swollen lymph nodes, and then developed this characteristic rash. With this current outbreak, there was a paper that was published, I think last week. It was a large case series, showed that only about 60% of people actually had fevers, swollen lymph nodes, and chills was another common symptom. Those symptoms would be common, but they don't have to happen. The symptom that everyone has is rash. So every single person with monkeypox thus far has had a rash. And so that's really we're looking for all these other things, but the rash is really what we zero in on if we're really concerned. Okay, this person may have monkeypox. The other common symptom with this outbreak is anorectal pain or tenesmus, probably because there are lesions in that area that you may not be able to visualize unless you perform anoscopy or something like that, but they can be very painful. And then the other important thing to highlight is we are seeing other sexually transmitted infections in folks with monkeypox. So just because someone comes in and you diagnose them with chlamydia or gonorrhea doesn't mean that, you know, you don't have to stop looking in the right kind of clinical context. So these are lesions. These are from classic kind of, you know, either in endemic areas or kind of these previous outbreaks. So you can see these, you know, very obvious raised either rubbery lesions or kind of pustule lesions. Sometimes they'll have a little dimple in the center, but really hard to miss, and they oftentimes occupy, you know, the majority of the body. So really hard to miss. This current outbreak, these are some pictures kind of from the you know, first few weeks of this outbreak. You can see they really can run the gamut. So you can see, you know, a couple of these lesions, you know, have a kind of a dimpled center. Some of them look more like pustules or acne lesions. Others, you know, scabs. So they really can run the gamut, and you can have lesions all over your body. You can have one isolated lesion. And so it really, you know, part of the challenge, I think, with this current outbreak is really having a high clinical suspicion in the right person with the right symptoms. Do a really good physical exam and really look for lesions. They don't have to be very impressive, and not, you know, oftentimes they're not super impressive. So whom to test? It's really someone with the symptoms I described, particularly the rash, who has been in close contact with someone who was diagnosed with monkeypox, or has been, you know, in close or intimate contact within a, you know, currently a, you know, high risk social network. So that would be men who have sex with men or transgender persons. Again, there are isolated cases of people outside of the, you know, that don't fit neatly into these criteria, but by far, you know, most of these cases thus far have been in men who have sex with men or transgender persons, or close contacts to someone diagnosed with monkeypox. So how to test? There's lots of people looking at, you know, kind of, you know, different modalities, but the best way to test right now is to swab lesions. And what we do at the public health department is, if we're concerned someone has a monkeypox, we'll swab their lesions, send the swabs into the state lab in Raleigh, and they'll do the orthopox PCR test. There are now other commercial laboratories as of 2 or 3 weeks ago who have come up and are doing these same tests and have really dramatically increased the testing capacity. Obviously, they charge. So for someone that's uninsured, you know, doing testing through the state lab, you know, makes the most sense. UNC is one health center in our area that they're doing their own internal monkeypox testing in their lab. And the national capacity now is about 70,000 tests per week. So it's not really a lack of tests currently. There's enough capacity. So the treatment, there are some off-label medications. The medication that's primarily being used, particularly for folks who have either have a lot of lesions or have, you know, lesions that are in really sensitive areas like the mouth or the anus, or have, you know, are just in a lot of pain, are getting this TPOXX medication, which is available either through the CDC or through the state health department. There's no specific antiviral medications that specifically target monkeypox, but TPOXX works pretty well. And then the primary treatment is home isolation. So that can range. Folks should isolate for the duration of their symptoms, and that's typically when the lesions scab over, the scab falls off, and there's new healthy skin underneath, and that can run from typically 2 to 4 weeks. So it's quite a bit longer isolation than with COVID. Prevention, I'll just talk real briefly about ACAM2000. That is a vaccine that's been around for quite some time. It tends to have, it's a live vaccine, tends to have more side effects than JYNNEOS, and it's not just a intradermal or a subcutaneous injection. You actually have, you have to use a multi-pronged lancet, and you vaccinate someone through scarification. It can be very painful and relatively, cause some bleeding. And so most places or most people aren't using ACAM 2000. It's really kind of like the second tier immunization. JYNNEOS is approved for the prevention of monkeypox and smallpox, and that's what most entities are using, and we're using at the public health department. So we're using it for two indications: pre-exposure prophylaxis, so someone that's not been exposed to monkeypox but falls in one of the high-risk groups, and then post-exposure prophylaxis, so someone that's been exposed to monkeypox and wants to get vaccinated. If given within 4 days of exposure, it's very effective at preventing monkeypox. If it's given 4 to 14 days after exposure, may not prevent infection, but can reduce the severity of symptoms. And it's 2 doses, so you give it on day 0, and then 4 weeks later, you give the second dose. And up till now, it's been it's been given subcutaneously. The FDA released some guidance yesterday. I believe that it can be given intradermally, like a tuberculin skin test. And the advantage there is you only have to give 1/5 of the dose that you give subcutaneously. So that is probably what a lot of places will start doing, including us, and it's going to allow us to kind of stretch the limited doses by a factor of 5. And the efficacy is equal if you give it intradermally to subcutaneously. So there are definitely some advantages. These are the groups that we're targeting now. This is kind of guidance from the CDC and from the North Carolina Health and Human Services. So currently the criteria for getting the JYNNEOS vaccine is if you've been in close physical contact with someone diagnosed with monkeypox, or you're a man who has sex with men or transgender person who reports one of the following in the previous 90 days. So multiple or anonymous sex partners, a diagnosis of a sexually transmitted infection, or you're on HIV PrEP, pre-exposure prophylaxis. And you can see here, I won't read this off, but the JYNNEOS has been dispensed in North Carolina in a series of waves. And you can see, with the first wave, we got 62 doses, then, 440 doses, 300 doses. And then during the phase 3 wave, got 760 doses. And that's the supply we're currently using right now. So we are providing JYNNEOS vaccine by appointment down at the county Monday through Friday in our second floor conference room. As of close of business today, we've provided 646 vaccinations, the majority first vaccinations, but some second, and we're vaccinating about 60 folks a day. We're one of the 7 vaccine hubs in the state. So not only do we provide vaccinations down at the county, but we've been pretty actively transferring vaccinations elsewhere. So you can see the list here. Harnett County, Orange County, we've been supplying UNC, Duke, and we're should be supplying NC Central and Lincoln Community Health Center within the next couple days. In addition to vaccinating down at the county, we're planning a vaccine outreach event next Thursday at the LGBTQ Center of Durham. And we're going to have a presence at Durham Pride next month as well, and hopefully vaccinate there. So just kind of in sum, monkeypox is not a new virus, but we're certainly seeing that this virus is behaving differently with this current outbreak. And not only is the symptomatology different, but the kind of the folks who are at risk is different. I didn't mention, but during past outbreaks in endemic areas of the world, children are really, the most likely people to get infected. And so this current outbreak really is behaving differently. JYNNEOS is a good tool in our toolbox to prevent infection. And we are really working hard to try to make sure that we're vaccinating in the most equitable way. And so working hard to kind of reach everyone, especially folks who are Black or African American, because they are, right now, the group that is the most highly impacted right now. And the primary treatment is isolation, but there is a medication that we can give if someone's having really severe symptoms. So that's kind of the monkeypox update I had. I'm really happy to entertain any questions that you all have for me.
Dr. Jenks, I did have a question. Thank you first for the presentation. It's very informative. With monkeypox being endemic in 10, 11 countries in Africa for decades, are there any hypotheses in the public health community about what is causing this recent outbreak? And are we seeing an increase in occurrence in Africa as well?
Yeah, so good question. So the first part of your question, so one theory, and there may be multiple things going on, but one theory is, we were vaccinating against smallpox for decades, and the smallpox vaccines that we were using decades ago were very protective against preventing monkeypox as well. Well, last case of smallpox was in 1976, and globally we stopped vaccinating against smallpox in 1980. And so one theory is that people who were either had smallpox or were vaccinated against smallpox now are either dying just of other reasons, or the protective effect of the vaccine is wearing off, and it's just giving monkeypox more room to cause problems. So I think that is one theory. Now, why this all of a sudden we're seeing such a huge outbreak now, where we didn't see a surge in cases 2 years ago, 3 years ago. I'm not entirely sure. That's why I in one of my first slides I just threw this in there, even though this is somewhat conjecture at this stage, that we may be dealing with a new clade. There's some data that this, I'm not going to call it a subvariant, but the monkeypox virus that we're seeing now has some genetic mutations that make it dissimilar from kind of the other two clades, and so we may just be seeing a new clade, or almost like a new subvariant that is walloping us right now. But I think so. It's probably multifactorial. But one of the theories I've heard bandied around quite a bit is, people just aren't getting vaccinated against smallpox, and monkeypox vaccination isn't routinely done anywhere, as far as I know, and that's at least one reason. But it's a good question. And sorry, can you repeat the second part of your question?
Yeah, are we seeing an increase in incidence in those endemic areas and in other parts of Africa where it's not endemic?
Not really. The vast majority of cases are occurring outside of these endemic areas, and it really is right now in this specific population. So men who have sex with men primarily. And so I think the prevailing theory is it's taken hold, and because these sexual networks are relatively small and closed off, it's kind of causing lots of problems in within that community, in that sexual network. And there's no reason to think it's going to just stay in those sexual networks, that men who have sex with men are more predisposed to getting monkeypox inherently. There's no data to back that up. It's circling through kind of that community right now, and will probably, if it already hasn't, jump out into kind of other sexual networks. But because monkeypox typically is not considered a sexually transmitted infection, that it primarily occurs in children through close contact with another child or a parent, non-sexual, that we're not seeing a surge in cases in those endemic countries.
Thank you.
Good question. Happy to answer other questions. If not, I'll stop sharing my screen, and if other questions come up, happy to answer them.
Okay, great. Thank you, Dr. Jenks. That was very informative. Very informative. Any other questions or comments for Dr. Jenks? on that or any other topic while we got you here?
I'm
All right,
always
well-
available by email. If you guys, if anyone has questions, just shoot me an email.
Okay, great. Thank you so much. All right. We are, oh, the budget amendments. We need to accept this money.
Yes, ma'am.
Director
And
Jenkins.
special thanks to the board for hanging in there. Lots of good information in this reconvening of the Board of Health meeting. 4 budget amendments for your consideration. I will tell you up front, 3 of them are rollover funds from our COVID fund. So, we just need your authorization. The first of which is a budget amendment to recognize $1,433,151 from the North Carolina Department of Health and Human Services, Division of Public Health, Epidemiology and Communicable Disease Branch. Once again, this is to continue our COVID testing and COVID work overall. The second is a budget amendment to recognize $728,148 from the North Carolina Department of Health and Human Services, Division of Public Health, Epidemiology and Communicable Disease Branch. Again, COVID work, emergency, public health emergency to respond to it. The third is a budget amendment to recognize $262,706 from the North Carolina Department of Health and Human Services, Division of Public Health, Women and Children's Health, Children and Youth Branch. Again, this is for school health nurses to respond to COVID-19. They've been doing a fantastic job. And the last is a budget amendment to recognize $20,000 from the North Carolina Department of Health and Human Services, Division of Public Health. And this is mainly for tobacco prevention. As this board may be is aware, Durham hosts the regional tobacco control manager. That's Natalie Thompson. She does a fantastic job, very passionate about what she does. This $20,000 is only been a part of $112,272, but we split that money between several counties to include Durham, Chatham, Orange, Alamance, Guilford, Rockingham, Caswell, and Person. Those are your 4 budget amendments, Madam Chair.
Okay, all right, thank you. Any questions or comments about those? Well, we're never going to say no to money. I don't think. So I will entertain a motion to approve the 4 budget amendments.
I just had a quick question,
Yes.
Director Jenkins.
Yes, sir.
And just more for the paperwork. I was reading over the budget amendments, and for the county manager's recommendation, I just saw that I guess the verbiage is to recognize fund an amount of $877,282. It repeated 4 times. Was
We
that on purpose?
apologize for that correction,
Okay.
for that mistake, but the original numbers are congruent, and
Okay.
we certainly apologize to this board for that oversight.
Okay, thank you.
Great. Any other question? Okay, we'll now entertain a motion to approve the 4 budget amendments.
Jim Miller here, motion to approve.
Second,
Curtis, second.
all right, any further discussion? Roll call vote?
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. McDougall,
Yes.
Mr. Curtis,
Yes.
Dr. Breakway,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
Commissioner Alam, Mr. Gregorio.
Yes.
Thank you.
Okay, motion carries. All right, next, excuse me, we're going to get an update on a recent external billing audit. Dr. Jenkins will update us on their findings regarding that.
Thank you, Madam Chair. To the members of the board, simply want to apprise the board of an external audit that was conducted this spring on our billing unit. The audit did come as a recommendation from several individuals, to include HR, to include former interim health director, General Manager Pierce, just as a best practice. I specifically requested this audit period be conducted from the time that I became the public health director to the present. So that's from January 5th, 2020 to the present. We were fortunate to be able to contract with a company called Applied Medical Systems. They are one of the leaders in conducting billing audits, and they are very familiar with public health departments. So they conducted 2 site visits in their assessment of our billing unit. It's important for the board to know that the audit findings did not indicate any malfeasance or anything improper. They did find that our group of employees, they found them to be very knowledgeable in billing, and they take pride in their work, and they certainly know what they're doing. But of course, the audit did provide several opportunities for improvement for our billing department. Those areas include increasing accountability, increasing our utilization of our electronic health record system, which we all can attest that UNC Epic is still new to all of us. And also improving our billing team dynamics, inner working dynamics. So they feel that these deficiencies can be addressed rather quickly, and they eventually will lead to a more productive billing unit. So again, I want this board to know that we are committed to implementing these strategies and these recommendations, and Finance Administrator Will Sutton and his team have begun to work on this plan internally with the help of County Human Resources. So we look forward to bringing you some additional information. In the spirit of full disclosures, we also want to let this board know that we did have an administrative monitoring, and that's something that all local health departments partake in through the North Carolina Division of Public Health. It occurs every 2 years, and they do that to ensure that local health departments are complying with our consolidated agreement. That's the overall agreement that allows for us to provide public health services and get the funding that we have. That last monitoring for Durham Public Health actually took place in 2019. No site visits were scheduled in 2021 due to COVID. So prior to scheduling this monitoring visit, we reached out to the state because, again, I wanted to have some type of audit take place just to know how things were going, to check on our financial health. And the consultants first, suggest that we do this administrative monitoring. I thought it not robbery to just do both. So again, I'm reporting to this board about both activities. The administrative monitoring from the state took place on May 24th, 2022 and June 6th, 2022. And it was a combination of virtual and in person. They did come. And, again, the visit was random. They didn't necessarily let us know, but again, it was live on-site records selection. And as far as the results, there were 2 components of their visit. It was a fiscal component, which really drilled down on time documentation, expenditure reporting, budget process, and financial checklists. I'm proud to say from the financial component, there were no discrepancies found. The second component is the clinical administrative component, and that entails reviewing fee and eligibility policy, patient income eligibility for maternal health and family planning. We did have 6 funding conditions and 1 recommendation from the state. So again, that recommendation, the agency should follow our fee schedule and eligibility procedure. So whenever we have any findings that results in us having a corrective action plan, which is not necessarily a bad thing, it just means that we have to clear up any infractions that were found during the site visit. Want this board to know, again, Will Sutton and his team are on the ready. They are actively doing it. We did receive that official letter from their findings on July 13th of 2022. We have 45 days to respond with the corrective action plan to be drafted. And we're currently in the process of doing that. But again, I wanted this board to know, in the spirit of full disclosure, that these activities took place. We certainly want to make sure that our billing unit is doing all that it can, has the training, the tools, and all the resources they need to do a good job. And we appreciate the partnership with the state. We certainly appreciate our billing unit. So happy to answer any questions you may have at this time.
So just one quick question. We talked a little bit about staffing. How is the staffing in the finance department?
Staffing is, that's one question that we kept getting from the staff. They're, continue to say they needed more people. And as a part of that billing audit, external audit from Applied Medical Systems, they indicated that we have the right amount of staff. It's the accountability of ensuring that the work is divided equally and that the work gets done. And that's something that we're certainly working on to include possible changes in job description, and also including the ability for them to put some additional feathers in their cap with certifications for billing and coding to really make the most of their billing opportunities. So again, Madam Chair, they did feel like we have the right amount of staff to take care of our operation.
Okay. So some additional training, perhaps.
Yes, ma'am.
All right. Great. Any other questions for Director Jenkins? Okay, well, good. Great. Thank you. Thank you for keeping us updated with that.
Absolutely.
All right. So our next meeting, September, is already September, I tell you. So I guess right after school starts, I kind of like to hear about what the nurses are seeing in the schools. I don't know if our next meeting is a little early because I don't keep up with the starts of school, starts and stops. So I don't know if September would be the right time to get that update or.
Happy to provide you with an update, Madam Chair. They will have their kickoff on Monday, and myself and Deputy Director Liz Stevens will bring some greetings. And by the time September comes, they should be up and running.
Okay, all right.
Attorney Wardell did have his hand up.
Yes, I'm sorry.
Just wanted to remind everyone that the state of emergency will be lifted on August 15th, the governor's state of emergency, which also with that takes away the ability to have remote meetings by this board. So the meetings will need to be in person. It does not prevent committees within the board from meeting remotely. You can do that.
Right.
But our main board meetings will need to be live and subject to the open meetings laws. So
okay,
there you go.
All right, good to know. We got to do what we got to do. Y'all just find me a place to park.
Well, and
I might just
that
Uber.
is,
I'll just Uber.
well, that's part of the reason I'm bringing it up, because I'm sure, Director Jenkins knows very well the parking situation is bad and possibly about to get to be worse. So just wanted to bring that up so that logistically we can make that happen. So.
Okay. All right. Great. Thanks. We'll certainly plan on doing that.
Okay.
All right. Going forward. All right. Any other questions or comments for the good of the order? Other topics for next time, in addition to school, if we need be? I still think we're going to hold off just a little while longer. I still want Bull City United to come talk about what they're seeing in the community related to violence, but I know they're undergoing some reconstruction is not the word, but I know, they were looking for a director and some other things. So they weren't quite ready for that. So maybe for October for that. I don't think they'll be ready next month for that either.
I did see something in the paper about they getting a new facility.
Oh, really? Oh,
yeah.
Yeah. And
okay, so they got a lot going on. Okay.
So might
All
be
right,
a good
good.
time to talk about it.
Yeah. You saying September or October? You think September will?
I think October will probably be better.
Yeah.
Give them an opportunity to kind of, get settled, if you will.
Yeah. So we'll say the school update for now, and I'm sure something will come up between now and then that we'll need to learn about.
All right. I have something to kind of run past you, Madam Chair.
Okay, right now?
Nah, I can wait.
Oh, okay. Anything else? Also, a few of us did participate in the board training this afternoon. I saw Dr. Miller. If it wasn't him, there's another Jim Miller. And Dr. Orto was on. So it was really interesting. They talked primarily about all the different kinds of boards there are in North Carolina and how they're governed. So it was really interesting. It was good.
This was done through ANC.
Yes.
CH. Okay.
Right. Yeah. And the folk at UNC, government did it. So it was
Awesome.
very good. All right. And it's going to be on, the whole presentation is going to be on their website, ANCC. And they're sending it to all the participants. So if I get it in the email, I can send it to Rosalind to send out to the board. It was good. It had a lot of good information.
Thank you so much.
All right. So if there's not anything else for the good of the order, I will entertain a motion to adjourn.
Motion to adjourn.
Second.
Second.
Okay, it's been moved and seconded to adjourn. Roll call vote.
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. McDougall,
Yes.
Mr. Curtis,
Yes.
Dr. Braithwaite,
Oh, she had to leave. She's on call.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
Commissioner Alam.
She had to
I
leave.
think
as
she had
well.
to leave too. She might be birthing a baby.
Mr. Gregorio.
Yes.
Thank you.
All right. Thanks, everybody.